Assalamu alaikum, friends. So today I am again with two important topics. This is important in your practical exam and also in your theory exam. So we often get these cases because these cases are easily available in outpatient department on the day of exam. So generally we keep these cases as short case in your final practical exam. So let us start with the first case. So if you go by clinical scenario here, a 30-year-old female patient, she had swelling along the volar aspect of the wrist. She noticed this swelling 3 months back, and there is no noticeable increase in the size of the swelling over the period of the time. And she gives history of surgery for swelling, similar swelling 6 months back at the same site. So this tells that it is a recurrent thing. So if you see here, this is the clinical picture of the swelling. So if you see there is a swelling on the volar aspect, a small size swelling. So this is ganglion. Ganglion. Okay. What is ganglion? Ganglion, otherwise called as ganglion cyst, because it is a fluid containing lesion. So it's a cyst. It's a mucin-filled synovial cyst. So it's a mucinous degeneration. So generally, they are examiner asked in practical viva what type of degeneration you get in ganglion cyst. It's a mucinous degeneration. So it may arise from the tendon sheath or it may arise from the synovial joint. There is no true epithelium. It is lined by just false epithelium in the form of fibrous lining. So it's to recall, it's a mucinous degeneration arising either from the tendon sheath or synovial joint with no true epithelial lining. So it can be on the dorsal aspect of the wrist, dorsal carpal, or volar aspect of the wrist, volar carpal, or around the interphalangeal joint. Even it happens in lower extremity involving the angle joint, disfranc, that is subtalar joint, and sometimes torso-metatarsal joint. If you see here, this is the dorsal aspect of the finger, interphalangeal joint, you are having cyst. Here, if you see, there is a dorsal aspect of the wrist along the intercarpal joint. Here, if you see along the volar aspect of the wrist, volar intercarpal joints. And here over the foot in tarso-metatarsal joint. So it can happen anywhere where we have synovial joint. What is the mechanism? Mechanism, it may happen following the trauma. After trauma, what happens is there may be some breach in the synovial lining. After trauma, breach in the synovial lining, and the synovial fluid comes out of this one side. It is lined by fibrous tissue. There is no true epithelium. Or it may be mucoid degeneration directly. As I told, it may be a synovial herniation. So what is the pathology? Fluid, it is filled with the fluid either from the tendon sheath or from the joint, mucinous fluid. There is no true epithelial lining. It is lined by the fibrous tissue, fibrous lining. So most of the time, patient will have no symptoms other than just swelling, and they have issue with the cosmesis. They feel a little awkward if they are wearing half sleeves or when they are doing some work exposing the wrist joint. So cosmesis is the main issue. If you do clinical examination, there is transillumination test positive. Why transillumination test is positive? Because it's a clear fluid of the mucinous degeneration. If you put light from here, so you see transillumination of the cystic cavity. So transillumination test is positive. On palpation, it is firm and well circumscribed, and it is often fixed to the deeper tissue, but overlying skin is normal. So this is how you differentiate it from other regions of skin and subcutaneous tissue. So if it is little bigger in size or sometimes in the structure areas where we have neurovascular bundles. I mean, if it is in popliteal region, if you said, or if you have in the cubital region, so it compresses the nerves. So popliteal or cubital region, it compresses the nerve and the artery and present as a neurosystem compression, which is not very common. Then how will you diagnose? The diagnosis is basically a clinical diagnosis, but if you want have some doubt that it is like some other swelling like fibroma, neuroma, or something like that, you can do MRI or ultrasound. That will give you the extent of the swelling, type of the swelling, and the contents of the swelling. Once you have diagnosed, you need to go for treatment. So you need to counsel the patient if it is not harming the patient, and just keen observation is what needed. Sorry. So first is observation. If patient still wants some treatment, you can do aspiration of the fluid. We can aspirate the mucinous fluid collection, and we can give intralesional steroid injection. As I told, we can give either long-acting methylprednisolone or triamcinolone. If patient is having recurrence or the swelling is causing compression over the neurovascular tissue, we need to go for surgical excision of the tissue. So there is an old treatment available. It described in your textbook, but nobody does that. That's called as Bible treatment. What is it? You need to hit the swelling with some hard book. So in olden days, the only book available in the house is Bible. So they use it to burst this ganglion. So that's why it got its name as Bible cyst, as Bible is the most common book available in the house to crush. So this is how you treat patient who is having ganglion. We'll move on to the second topic or second case. If you see here, the second case is 25-year-old male patient. He had swelling along the volar aspect of the wrist for 2 months. The swelling shape is hourglass shape, and there is symptoms of median lung compression. That is, patient is having something like carpal tunnel syndrome presentation. So if you see here, the patient is having swelling here. So it is more like hourglass swelling. Okay. If you see, this is hourglass. So the swelling is hourglass swelling. So this is how the patient with compound palmar ganglion present to you. So what is compound palmar ganglion? It's a chronic synovial sheath inflammation. It involves the flexors of the hand extending through the ulnar bursa of the hand. So it's a compound palmar ganglion. So before going to the compound palmar ganglion pathology and presentation, we need to know little about the anatomy. So what are the important things you need to remember in anatomy? We need to know what is the extent of the synovial flexor synovial sheath. So flexor synovial sheath is a bursal sheath extending distal from the distal forearm of the hand. It goes under the transverse carpal ligament and continue as ulnar bursa. So if you see here, this is your ulnar bursa or flexor sheath. Here it is covering all flexor digitorum superficialis and profundus, 8 tendons. So it start here, and this is transverse carpal ligament. Under this, it will go and continue as a ulnar bursa. So if any swelling is happening, it will happen here like this. It happens here like this. This transverse carpal ligament act as a constriction. So the swelling is like this. The swelling is like this. And it is directed more towards the ulnar side because it is in continuity with the ulnar bursa. So this is compound palmar ganglion. So proximally it extends till space of perona surrounding FDP and FDS. Distal is continues as a bursal sheath for bursal sheath of little finger. Okay, what is happening or how compound palmar ganglion is forming? So there is inflammation due to the disease process, chronic disease, which cause increase in the fluid in the bursa. So this fluid bulges out and take the shape of hourglass due to the constriction at the level of the transverse carpal ligament. So what are the conditions where you have this inflammation in chronic conditions like infection? infection of tuberculosis, chronic tuberculosis tendon and sheath infection, and sometimes it happens in inflammatory disorders of chronic origin, that is rheumatoid arthritis. Hope I am clear to all of you. So we find two classical bodies here. One is called melon seed bodies, other is called rice bodies. If you see here, this is how the melon seed bodies are. So this is the melon seed bodies. Okay, how the melon seed bodies are forming. So there is micro fractures happening after the synovial inflammation and ischemia. So this will get shed off from the parent synovial lining and they get encased by the fibrin. Or other theory is there is de novo formation due to fibrin. The fibrin, multiple fibrins are getting adhere to each other and forming this one. Sorry. Or there is there happen due to the inflammation, there is alteration in the fluid viscosity. So, and due to alteration, it will condense and forms the bodies. So, just the thing you need to remember is melon seed bodies and rice bodies, which we see in compound palmar ganglion. And compound palmar ganglion is seen in the chronic conditions, which called synovial sheath inflammation. Common is tuberculous tenosynovitis, or second common is rheumatoid arthritis. So there is a presentation with the swelling along the wrist joint. They have symptoms of median neck compression and other systemic manifestation of disease. If it's tuberculosis, there will be all associated symptoms like malaise, weight loss, the poor appetite and all. If it is rheumatoid arthritis, they have other presentation of rheumatoid arthritis with multiple synovitis, deformities and all. So what are the investigations? We do X-ray to know any joint destruction, because both in tuberculosis and rheumatoid arthritis, there will be involvement of the joint and there is destruction of the joint. We do ultrasound to know extent of the pathology and MRI also to extent of the pathology. If you see, this is the MRI image. You can see our glass cystic swelling extending under the carpal ligament in arm and forearm and the wrist. And this is ultrasound finding. Here you can see the melon seeds bodies. So once you have diagnosed the patient with compound palmar ganglion, you need to treat the patient. How will you treat? The treatment is surgery. So what we need to do is we need to debride and excise all the hypertrophied synovium. What happens if we won't do surgery is the inflammation goes on increasing and it may damage the flexor tendons completely. And after doing synovial, we need to send it for biopsy. And if you are suspecting tuberculosis, you need to go for culture. So this is how you can differentiate whether it is tuberculous origin or rheumatoid origin. If you find the test favoring your tuberculosis, then you need to give anti-tubercular treatment. If the clinical findings and histopathology favors rheumatoid arthritis, then you need to go do disease-modifying anti-rheumatoid drugs. So this is how we give the incision. Incision is starting from the distal forearm, then carpal ligament, then extending towards the hand. So here is your transverse carpal ligament. That, so we need to release the transverse carpal ligament also. Hope I am clear to all of you. Please let me know your views in inbox.